Hello and welcome everyone. We are pleased to present this follow-up webinar on the Swedish handling of the coronavirus with a different angle this time. So a month ago, we had the webinar with Anders Vahlne and how Sweden is handling COVID-19. And I think a lot of people were pleased to hear about that and get more information about how Sweden is doing. But some people reached out to us and not everybody were happy. We got there was a concern that we should also give a voice forum to the critical voices of the handling in Sweden, and amongst them were Science Forum COVID-19. And as an organization here in San Francisco, we have no bias in this, but I think it's important, especially in these polarized times, to allow for different opinions to be able to express themselves. And on a personal level, I'm really curious to better understand what is going on and why actions and reactions over the world are so different. My name is Mats Andersson, and I'm responsible for the Swedish American Chamber here in San Francisco, Silicon Valley. And with us today, we have Dr. Anders Vahlne. He is Professor Emeritus in Clinical Virology, Division of the Clinical Microbiology at the Karolinska Institutet, and previously Chief Physician at Karolinska Institutet and Karolinska Hospital in Huddinge. He has researched extensively on HIV and herpes simplex virus, and he is also chairman for the Science Forum COVID-19. Thank you, Anders, for being with us today.
Thank you for inviting me.
And for the rest, we have the same crew as last time. Lars, over to you, a couple of words.
Yeah, thank you, Matt. Yes, so and thank you, Anders, as well, for being with us. So my name is Lars Johansson. I have lived in the US for close to 30 years. I'm a practicing attorney since a little bit over 20 years. The reason I'm here today, though, is not in my capacity as an attorney, but for the first time, and having traveled most of my life, Sweden became controversial in the spring. And we hear it from time to time in discussions with friends, but often among business people, where we're asked to explain the Swedish approach. And I think that was the impetus to my participation here. Thank you, Mats.
Thank you, Lars. And we have my colleague Saga, over to you.
Yeah, thank you, Mats, and hi, everyone. After high demand for our webinar with Tegnell that we hosted in late August, we got a request about hosting this follow-up webinar with a more critical standpoint when discussing the Swedish Corona strategy. Therefore, we're very pleased to have Anders with us today. And we are also very glad to see the audience being engaged. And there are definitely many opinions whether the strategy is good or bad. It will be possible for all of you to ask your questions in the Q&A box that is below. So just write them there, and please make sure to keep them short so that it's easier for us to keep track of them. We will do our best to address as many questions as possible. And I hope you enjoyed this webinar. As we only have 1 hour, I think we should get this started.
Thank you, Saga. So let's dive into it. Anders, tell us a little bit. Well, in the spring emerged these 22 scientists that we were reading about, even over here, that had a critical view, and I think that later became Science Forum COVID-19. Tell us a little bit more about that organization and what the aim is, and if you can also then jump into what is the main critiques that you are having of how Sweden has been handling the virus.
Yes, we were some researchers and physicians that had written a few debate articles, critical debate articles, how we were handling the COVID pandemic. And we got together and as you say, wrote that debate article in Dagens Nyheter, the largest Swedish newspaper. And some of the wordings there upset a few people, particularly the ones at the Public Health Agency, and that's why we became known as the 22. Our aim was not really to upset, but we were critical, and we think in scientific society one has to be able to discuss. So we formed this group, and so we started with 22. Now I think we're up to almost 50 of us, and we have people with different expertise. So it's a science-based society, and we try to spread unbiased scientific information about the COVID-19 pandemic. And our mission is really to save lives and to prevent suffering from the pandemic. So our overall goal is really to minimize the impact of the pandemic. So the goal is not to oppose the public health agency all the time. And we think they're doing good things as well, and even more so now.
But isn't everyone trying to minimize the impact? And so I mean, you have the same goal as the others.
Yes, but well, of course they are. But sometimes what you do doesn't minimize the impact, and even though you think you are. And you asked about the critique we had, and really, if I take myself already in February, I was really astonished about the information that was given and the decisions that were taken by the Swedish government and the Public Health Agency. And I thought that either the Public Health Agency didn't read the science, because there were quite a few scientific papers coming out, but there were not that many, so you could actually read all of them. And to me, it was pretty obvious a number of things, like, for instance, that you had asymptomatic spread, that you had that children got infected and could infect other people, that you had aerosol spread, airborne spread, and so forth. And but then again, we didn't know all that much about the virus. And when you have a pandemic and the risk of a pandemic coming in, then you try to do as much as you can to stop it. For instance, by quarantining, isolating people coming from infested areas, which we didn't do. I mean, I was really surprised to hear the Public Health Agency even saying it was, you could fly and have holidays in the Alps. It wasn't any problem, and we know that northern Italy was in a chaos at the time. And so really, when then people came, you didn't isolate them, you didn't put them in quarantine when they came from the infested areas, and which one could have done. Also, if you did that, and like countries like, I mean, the same thing happened in Norway, people coming back from the Alps, but they put them in quarantine, and they did a quick lockdown of the country. And the reason for that is that you then can learn a little bit, it gives you time to learn about the virus, how it spreads. And for instance, in Sweden, we didn't have the protective equipment, personal protective equipment for the personnel in the elderly homes and in other places in the health system. And we were not prepared for testing. I mean, at first we didn't even have the tests. And the laboratories put up the so-called in-house tests, and then started to buy them from the big companies. But since everybody in the world wanted to buy them, there was a shortage. And so we couldn't test. And normally when you have a pandemic, you test, you trace those that have been in contact with the infected individuals, and then you isolate. And before you can do that, you really have to shut down the country.
You say this shut down the country, and I think that's something we could maybe discuss a little bit around. So I understand that the shut down of a country works in a short term when you think that this is really something we have to handle,
yes,
and get on the top of. But how is it long term? Because I mean, if we take here where we are sitting now, where I'm sitting in California, we are kind of in a semi lockdown for 6 months. Nothing is changing. So how much should you actually do a lockdown, and how long can you do this? Because it seems like the virus hasn't really changed nature since February, March, or maybe it has, but nothing has changed. So how long can you go on with these quarantines and lockdowns? And how much should a society kind of enforce rules on the, because that's the critique coming from the other side now, people who are lacking their freedom.
Yeah, well, as you know, I mean, it's we don't run around freely in Sweden either. I mean, we closed gatherings of more than 50 and so forth. Even though we kept restaurants open, everybody above 70 have had a lockdown in practical senses. So it's not that we haven't done measures in Sweden, and then even the voluntary measures that people have been doing more than what's recommended. So we have been hit by the COVID-19 pandemic in that sense. But I mean, when you don't know anything, I mean, this could have been extremely deadly. I mean, the video clips we got from Italy was devastating. People were dying and dying and dying. I mean, and not only elderly people, also younger people were dying. So before we didn't know, and we didn't really know how the virus spread. And those countries that did a quick lockdown did well. Take Norway, for instance. They at the beginning had the same problems that we had, and as many people were coming into the country from abroad. I heard that others been saying that that was not the case, but it was. If you get the statistics from the airports, and so that was not the difference between Sweden and Norway. And we've had per capita 10 times as many deaths in COVID as Norway has had. But they did a lockdown. Take Finland, where they did a lockdown, and even, I mean, they isolated Helsinki for a couple of weeks. And of course, as you're saying, you can't do it forever. And but you have to buy time, and the amount of science that came out was, a tremendous amount of science, and so we learned very quickly. And of course, another way is not to learn, also to the healthcare system to learn how to treat, and we're much better in treating the virus infections today than we were, in the spring.
Yeah, I understand that is a big change in how patients are treated. What if now it seems like Sweden is coming out as someone is praising the Swedish handling. So what if the cost was high in the beginning, but ultimately now it is the winning strategy?
Well, really, I mean, what is that to praise? We got 60,000 deaths, and our neighboring countries, Finland and Norway, had less than 300 deaths each, and Denmark, which is very densely populated, much more densely populated than Sweden, has had about 650 deaths. I don't know the exact number. So we've done poorly. I mean, we've had more deaths than the other Nordic countries together, but I think 4 or 5 times as many as the other Nordic countries together. And so, and one more thing, it's not only deaths. About 10% of those that get infected have long-term illnesses, and the virus causes damage to the lungs and scarring of the lungs. It causes damage to the kidneys and to the heart, and even injuries in the brain. So we don't know the long term of those that have been infected. And these long-term illnesses you see also in those that had a fairly mild COVID. And so I think one should try really to do as much as you can. Now, if you do lockdown, I mean, you can start losing the lockdown, where you see that when you find that it's an aerosol spread and so forth. For instance, we talked about face masks. You don't have to really, in my opinion, use face masks outdoors. It's indoors. You have to wear them. And that's one of the problems in many countries that have mandatory face masks, that you have to wear them, and you're fined if you're not wearing them outdoors. And then they take the face masks off when they're indoors, when they really need it.
We're on the topic of face masks. I actually wanted to add something, because on our last webinar on the topic, we had a lot of questions regarding face masks. Mm-hmm. What is your opinion on this? You were talking a little bit more about it before, but why do you think Sweden haven't implemented any guidelines regarding this?
Well, I must say, I don't know. It's I think that they prestige. I'm sorry to say, I think that's one of the reasons, because they said that face masks don't work. And one of the problems, I think, that there are no virologists at the Public Health Agency. They used to have, I mean, the predecessor, Anders Vahlne, was a virologist, and Annika Linde. And so at the start, I don't think they consulted virologists, at least not someone who knew about the biology of the virus. And one of the mistakes they did is that they had one way of solving pandemics, and that was based on influenza, and this virus doesn't behave at all like influenza. And also, if you compare it to the previous SARS, it does not behave at all like the previous SARS, because the previous SARS that we had 70 years ago, you were most contagious. You had excreted most viruses when you had been sick for 5-6 days. And when you start to get symptoms, you really didn't transmit the virus to other people. And here it's just the other way around. You transmit before you get sick. And you have most virus in your upper respiratory tract, the days before you get symptoms, and the few days after you start to get symptoms. A week afterwards, you don't have much virus at all.
Do you think that people may be less careful with face masks?
Okay.
Do you think that people might be less cautious with face masks? That people think?
No, I don't. Actually, there have been studies looking at this, and common sense tell you, when you see one with a face mask, you step aside, and you're reminded of the pandemic, and so I don't think. I mean, the health agency came up with all sorts of arguments for not wearing the face mask, and I mean, the rest of the more than 170 countries recommend face masks, and the WHO, the NIH, the CDC in the US, and the European CDC, all they recommend face masks, and the literature is very good now. Face mask doesn't work as well with influenza and other viruses, but strange enough for coronaviruses, they seem to work very well. And it's just to accept. At the beginning of this year, back in February, I didn't believe in face masks, and I gave talks about corona to people, and I said that face masks don't work. And now I'm absolutely convinced they work. And they save lives, and they prevent suffering. So I don't know, and I mean, it's a very cheap thing to do, to buy these face masks, and you can make them yourself.
But it's an interesting point you're saying there, that you don't think that they should be used outside, because here is clearly it's exactly like you say. People are supposed to wear them out, or are obliged to wear them often outside, and then they take them off and they go inside, and you can even be scolded going on the street if you don't have it here. So that's I think an important nuance that could maybe be wider brought would be good.
Well, of course, I mean, if you're in a crowded place outdoors, you could wear the face mask, and I would never enter a shop without a face mask. And in some countries in Europe, you can actually go without face mask outside, outdoors, but you have to wear them when you enter a shop. And I think that everybody should have a face mask when they enter a shop or any, for instance, public transportation or anything like that. And the people working in shops should wear them. I visited my doctor the other day at the hospital in Stockholm, and none at the hospital was wearing face masks. And so I don't understand that.
That sounds unreal from our perspective, how that can even be. Lars, over to you. Do you have something here?
Thank you, Mats. Yeah, I have, and I agree with you, Anders, that I think it's difficult to argue success when you have that many people dead and infected, and we have a similar situation here in the US. But I wanted to pick up on something you mentioned, that the Swedish Public Health Agency, they don't have virus experts. And it seems like sometimes these days an expert is born not every day, but every hour, and they appear on TV and so on. But yeah, my question is really twofold. But in your mind, is the challenge here, or is the issue, is it and if we were to listen to an expert, is this an issue of understanding the virus, epidemiology, societal behavior, politics? What is it that we need to really understand to come up with a good response to the pandemic?
Well, I think you need all. I mean, it's I don't think that anyone can say that they know everything. And we actually, in our science forum, COVID-19, we have sociologists, we have epidemiologists, we have virologists, and so we try to cover all aspects of the pandemic, and we educate one another. So I agree with you. I mean, it's not enough to be a virologist. I mean, like me, a clinical virologist, I'm a laboratory physician. I don't see patients. I mean, I do get the test sample from patients, but I don't see the patient. I don't take care of them. So one should have, experts that actually do that as well, and so forth. So yes, a lot of experts are popping up in the television. I've been one of them, not that frequently as others, but you need to listen to more than just virologists or epidemiologists.
Yeah, and my quick follow-up question on that is, so like Mats said, we have been dealing with this since February. I think the lockdown started in March. I have 3 kids that do online learning, one at the college level, and so many people lost their jobs. You have in California alone, I think about 450,000 kids get their main food from the school system, and even though I think most schools that do not do in-person learning these days, education, they do provide the food and so on, but the magnitude is huge. It's huge, and I think it's hard to even comprehend, and I think we will know eventually the cost of it all and the stress on society. But my question is, and here, in the US, we did all this, we took on this cost, And it's not clear that we are successful, the benefits of it. We're still dealing with it and so on. We're still in a partial lockdown. But if you look back, and now you've had a chance to compare the different responses, and we don't want to make this overly political, so I don't want to ask you about the US approach. But if you were to compare the different countries, and you mentioned you had learned things about the masks since February, March. If someone were to ask you today, and having looked at the different ways the countries approach it, would you answer differently today compared to a year ago?
From a year ago, yeah. From a year ago, I didn't know anything really about how this virus would spread. Nobody knew. I mean, if you take the two previous serious pandemics by coronaviruses, was the SARS in 2003 and 4, and then 10 years later, the MERS, the Middle East respiratory syndrome virus, MERS. They behave very differently. They were easy to isolate the patients, and here, because they, like I said, the people really spread the virus after they were sick. But here you spread the virus before you're sick. And my belief is that what's driving this pandemic is asymptomatic people without any symptoms whatsoever. And you should remember one thing, and that is that what we have learned is that automatically when we test if with the what we call the PCR method, where we look for the virus genome, the virus RNA in samples from the patients, we also get a hunch of how much virus there is in the patients, how much is excreted by the patients. And because the method is really that you double the amount of the RNA, which we transform to DNA, you double it in cycles. And when you done 1,000 cycles, you have 10 cycles, you have 1,000 times as much DNA in your test tube. And the assay is set such that when you have enough, you get a signal in the machine, in the instrument. And in some cases, you have to wait till, say, 35 cycles. Now, if someone else gets positive already at 15 cycles, that person has got 1 million times as much virus in their upper respiratory tract. And of course, those are the ones that transmit the virus, whereas the ones with less virus don't. And you can see that 5% of those infected transmit the virus to 70% of those that get infected. And if you get up to 80%, it's 20% of those that. So, of course, even if you have little virus, if you're really keen on trying to transmit, you are able to do it. But in practical terms, very few of those that are infected actually transmit. And they transmit, in my opinion, before they have symptoms, or if they don't have any symptoms at all. And the problem here is really that you can be one of those with 1 million times as much virus as others, and you don't have either any symptoms, or you're not very sick at all. So that's the tricky thing with this virus, and this pandemic makes it very difficult.
You mentioned these PCR tests, and thanks for explaining. Now I finally understand these cycles. That the more you cycle, the better you get the results, or the more likely you are to get it. There's a lot of critique around the PCR tests that now they are done extensively all over the world, and we get more and more cases. So some people argue that we're living in October in a case-edemic, with millions and millions of cases, but that the ICU beds are not stretched at all in the same way as back in March, April. So what do you say to that? And what is happening with the virus now? Has it lost potency as well, or?
Unfortunately, I don't think so, but it's too early to tell. And I mean, if we're lucky, it has been, the potency has gone down. For instance, one of the less serious coronavirus is a strain called UHK1. And it appeared in humans back in 2004. And at the beginning, it caused very severe pneumonias. But today, it just causes a common cold. And it doesn't cause pneumonia any longer. And hopefully that will happen with also this virus, but we don't know. I mean, it could go the other way. And we must remember that globally, I mean, this virus is still a killer. And so it will become technical, but this virus, the way it's constructed, it's a big RNA viruses, and like measles, and viruses with big RNAs don't seem to mutate that much, as opposed to, for instance, influenza, where because it's got a segmented, so influenza's got a segmented genome. It's 8 segments, and then the small genomes there it's more apt to mutate. But here it's, for the virus, it does mutate, of course, but every time it replicates in a cell. But you don't get viable viruses if it mutates. So, but of course it does. I mean, off and on it will, and it will change in time. It won't change that much. Well, some will change, but I mean, looking at the pandemic in practical terms, we have to consider, we have to look at the virus as it was this spring. But on the other hand, what has changed between now and the spring is that we are much better in taking care of the patients. And particularly, I think, in Sweden, where we were not good at all in taking care of the elderly. Many of them got palliative care. And today we know that, first of all, that you have to start treatment very, very early on. If you're trying to use treatments, drugs that affect the virus replication, the virus production, then you have to start treatment very, very early. And many of the drugs that were tested late in the COVID illness, and then there is not much virus production. So even if you stop the virus production, you don't stop the illness. So I think that we won't be hit as badly as we were in the spring. But still, I think people will die, unfortunately, from the virus. And you can see that in other countries, that people are still dying. Although I must say that, people are testing more, and in that sense, you get a case-demic, if you like, because we, for instance, in Denmark, they test 4 times as many per capita as we do in Sweden. And so, yes.
Yeah, so there's a certain truth to that. Saga, do we have any questions here from the audience? Or
I actually had a question regarding the elderly. It's in a potential second wave. Do you believe that Sweden is prepared to handle it better this time? If not, what would you suggest be a safety measure? I mean, Sweden is known for not taking care of the elderly very good. That is like one of the main critics that most people have, and that also Anders Vahlne was admitting that was like one of the big failures. So what would you say about a second wave there?
I mean, it is very, very difficult to take care of any group. I mean, it's not us, the elderly. We have lots of other frail people, risk groups. And I mean, it's a good, I can understand the idea that you should try to protect the frail and elderly. And we try as much as we can, of course, but it's extremely difficult. I mean, take the White House. I mean, you couldn't save the White House in Washington from the infection. And if you take the nurseries, the elderly homes, then they have had the same problem in Norway, and you've had exactly the same problem in Britain. So I think it's extremely difficult to really, because, and you should remember, this is an airborne virus infection, I'm about Sweden. Will we handle it better? We could, if we started to behave after what we've learned and have recommendations after what we've learned. I mean, if the Public Health Agency said, yes, let's use face masks whenever you're indoor and in crowded spaces and so forth. If they would say, teach people that, yes, this is something that is spread by aerosols. So think tobacco smoke. If you envision yourself that had someone been smoking in this room, would I be uncomfortable with having all that smoke? Then you should think that if there's someone in this room that is infected and you don't see it, and he doesn't know or she doesn't know, and is one of these super spreaders with lots and lots of virus and creating this aerosol that stays in the air, and you inhale it. So social distancing is very, very important. But so when you wear face masks, you shouldn't, skip social distancing. You should do both. You should, try to have as many barriers as you can. And if you do that, yes, you can cope with the pandemic much better than if you didn't do this. I mean, this teaching of washing hands, for instance, it's, yes, you can perhaps transmit the virus, but this virus does not seem to spread with fomites, the infected doorknob or whatever. It's really the aerosol and droplets, of course, if you inhale. So you have to inhale it and you have to have a high dose, then you get sick.
Another question on the spread, or the spreading from the audience, is how significant is the spread of the virus by people who don't have any symptoms at all as compared with people who have a cough? Is there any difference?
The short answer is we don't know. But then again, like I said, you can excrete extremely high amounts of virus without having any symptoms. And if you don't have symptoms, you move around in the society in a way. But if you cough and sneeze, you don't walk around. You probably stay at home. And even if you don't walk up to a person within 6 feet and cough them in the face. You try to cough them you teach them to cough them in your elbow. And of course, nobody says, the Public Health Agency doesn't talk about, they teach you should sneeze in your elbow, but they don't tell you how to take off your shirt or your sweater if you cough, and that you don't touch your elbow afterwards and infect other people. So with face masks, they do work, and I want to emphasize this. They do work. Please use them.
You say that they do work, but one thing here, you can have anything here as a face mask here in California. You can take a T-shirt or bandana and just wrap it around. Yeah. And I guess there's a big difference on what is working when we talk about face masks. It's not like anything.
Yes. But anything works. I mean, anything is better than nothing. And there are papers now that even if you take a cotton T-shirt, just like that, I think that reduces by at least 50% the aerosol that you produce if you're infected. And at best it should have, if you use cloth then you should have different types, satin and cotton and silk, and of course the tighter it is, the better it is, but then again you can't breathe. And it's these little aerosol droplets, I mean, down to 3 microns and even smaller. It's not like sieving. It's they get electrostatic attachment to the cloth, and so and the same thing. Those face masks you buy in the drugstore have different types of paper, and I don't know what materials they have, but they work. And so the quick answer is really yes, use anything if you don't have a good face mask.
I have a quick question for you, a little bit on a different topic, but I just listening to you, I wish we could invite you to the US and talk to the nation, to be honest, because I think we got stuck in a sort of a paralysis in a way. We're quibbling, we're debating masks when we know that many people don't feel comfortable without them, you know, and we can't move forward. My question is a little bit different. And I mean, it's been very impressive and comforting to see, just like the firefighters who are rushing to the fire, to see the medical doctors leave medical school to join the hospitals and to help out. So true heroes, unafraid, and all of that. But I wonder, in coming up with a response to the pandemic, I mean, as medical doctors in the medical profession, you have your ethical guidelines as well. And I wonder if sometimes you come up against them, and how do you navigate that for the medical profession? I know here they talk about this might be a game changer for a long time. There's a new generation of medical doctors coming out and so on, but any thoughts on that?
I'm not sure I got the question, but
the choices you have to make. I mean, when you've had some of these hospitals being so overwhelmed and so on, and a lot of
that's. I mean, when you're overwhelmed, you're in a terrible situation. I mean, when you start triaging, and I think we maybe have been a bit too good at triaging in Sweden. I mean, if you were 80 years old, or they wouldn't even admit you into the hospital. And I mean, if you take the intensive care units in Sweden, I don't know, 80% of those that died were, or 70% of those that actually died were above 80 years old, but only 118 of maybe 4,000 of those treated in the ICUs were above 80. So just a fraction, I think I calculate this to less than 5% of those that were actually treated in ICUs were over 80. And of course, when you don't admit the elderly and those that die, then you don't get overwhelmed. And so most of those that died in Sweden, unfortunately, they died at home, their own homes, or they died at the elderly homes, the nurseries. I think that will change. But it's a very, very difficult problem. And I mean, I don't think there was, you know, a policy really to be as harsh for the doctor. It's just that when you stand there and you fear that, you know, the next patient is going to be a 20-year-old, and whom I can save the life that you and I only got one place left, or then I mean it is a very, very difficult situation. I'm glad I wasn't there.
Yeah. And do you think there are just quickly in terms of coming up with a pandemic, the response? are there ethical guidelines? I mean, how does that work? Is that part of the response for the medical profession?
Well, I don't. We've asked the Public Health Agency what the ethical guidelines have been, but we haven't gotten an answer. So, my answer is I don't know. There should be, of course, but some sort of ethical guidance. I mean, every doctor. I mean, we got the Hippocratic Oath. I mean, we should, react and act according to that. We should try to save all lives, that lives are holy and so forth. But it's a difficult situation, I must say.
Some more questions from the audience, Saga?
Yeah, they're coming in fastly now. One is like, even though you are critical to the Swedish corona strategy, do you see any advantages compared to other European strategies? Like, are there any positive differences?
Well, not really, I must say. I mean, if you look at the countries that have done best, like Taiwan, 24 million people, and they had 7 deaths. New Zealand had 25 deaths. Sweden had 6,000. I mean, then it's difficult to say that the strategy is good, being good. Then you could compare, of course, if you like, with Great Britain and Spain and Italy. The problem with those countries is that when you try to compare, is that they are much more crowded places, and it's more difficult to keep the pandemic out, the spread of the virus out when you have 10 or 20 or times as many people per square kilometer. But the other thing is that those countries actually they started their lockdowns too late, and if you should be, if it should work, I mean, you should do it right away. Britain, for instance, that they were speculating about herd immunity, and for the first month they didn't do much. They did the same thing as Sweden, and of course the Public Health Agency in Sweden was very happy to have people that did the same thing. But then mathematicians and statisticians calculated that it would be too many deaths if you went down that road. So they imposed lockdown, but it was too late. Same thing in France. In Italy, of course, they didn't have time. But then again, in different parts of Italy, they could. I think in Rome they didn't have. They saved Rome and the southern part of Italy, but in the northern part they just couldn't stop it. And in Sweden, I mean, since we didn't stop it at all, we started with testing and tracing. But 2 weeks or a couple of weeks into the pandemic in Sweden, the epidemic in Sweden, they just gave up. It was too much, and I hope that we're slowly approaching the same strategy as other countries, but in my mind, we're doing it too slowly.
Some other questions that we have gotten a few of is something that Lars was discussing before. That is the school closings and schools opening in Sweden. Like Lars said, children in the US are not allowed to go to school. But in Sweden, we have the opposite, that the families are kind of forced to actually put their kids in school. So one question is, in Sweden, we have the opposite situation than in the US, with families with members in risk groups being forced to send their children to school. How do you assess the risk from children and families with members in risk groups? Do you think this is fair, or how do you think we could handle that better?
I think we should handle it better. I mean, it's the Swedish law says that you have to go to school, But when you have risk groups, and like I said before, I mean, children do get infected and they do produce a lot of virus, and of course they are infectious and they spread the virus. There was a big study published in Science just a week ago. They looked at, I think, more than 600,000 patients and children. And they saw that children, yes, they did transmit the virus, but children transmit virus mostly to those that are the same age, because they don't social distance and they play and they infect new others. And of course they can infect in the family. And so 5-year-olds infect 5-year-olds, 10-year-olds infect 10-year-olds, and so forth. And should we close the schools? It's difficult. I mean, we did close these schools. I don't know what that's called in the US, but from the 16 years olds and older. They didn't go to school, but the younger went to school, and I think that it's important for children to go to school, but if they go to school, why not let them wear face masks? In other countries, they do, and they can. I mean, it's not a big deal, and the children like it. And I listened to a paper. We had the Global Virus Network. It's an association of virologists in 33 different countries, and we had a web-based meeting. And there was this researcher from Hong Kong who gave a talk. And they had their 15, when they opened the schools, they knew of 15 cases where they had children that could spread the virus, but they didn't. And the thing they did there was that all children, even less than 6-year-olds, wear face masks. And they had social distancing, and they had staggered start of the schools for the different children. So if you have the measures, you could have the schools opened, and like Mats was saying, I mean, in many cases that's the food children get, and they socialize and they learn things hopefully as well in the schools. So yeah, but you should take precautions, and when you do that, you can actually prevent the spread also amongst children. But of course, if you're a risk group, I mean, it's to force someone in a risk group to send his or her child to the school with the risk of getting infected. I think that's awful.
Is that the case in Sweden? Can I just ask?
Mm-hmm.
Is that the case in Sweden, that if you have?
Yes, it is the case. It's Swedish law that, and if you don't, I mean, the headmaster of the school, contacts the family, and if they still don't send the child to school, they contact the social authorities, and they make they force you. They may even take the child away from you.
That will be the next seminar, I think.
Yeah.
Hopefully, I mean, the schools will treat this, and the headmasters will treat it wisely, I hope.
But it seems like face masks can actually help out in many situations. Like, people are also discussing the fact that having people not going to school or kids not going to school might be bad for their mental development, and also people might be have more mental issues and such things. But we have one question that is, considering that the mask issue seems to be about prestige, what could it take for the decision makers to change their stance and recommendations, do you think? At least in like hospitals, elderly homes, schools?
I wish someone could tell me, because, you know, when I was at the hospital, I brought that up, and they said, well, we don't have any recommendations to wear masks, so we're not wearing masks. Then I have a relative who's Professor Geriatrics, and he just came back from sabbatical in Canada, and he's seeing patients and you know, take the medical history with the patients in a small room and poorly ventilated, and he wears a mask, and he says that all his patients will have to wear a mask when he's examining them and you know, talking to them. But his colleagues, you know, are mocking him, and I think that's, you know, I don't understand it. I mean, it's such an easy thing to do. So my question, my answer would be that in order to implement it, the authorities should say you have to do it.
Another question about the risk groups. How do you believe they can handle the situation in the best way, like with the current or present situation? I mean, how can they practice like social distancing? What can they do to make the best of the situation with the recommendations there are?
Yeah, I mean, if you socialize, do it outdoors, and that's why I'm you know, spending my time at my summer cottage, and we have an outdoor place with electric heaters, infrared heaters, and so we have, you know, meet other people there. It's so if you meet someone, first of all, don't let people into your house, and don't enter other people's houses. Don't go into shops, but I mean, do walk outside. You don't have to wear a mask, and if you really have to be indoors, wear a mask and ask them to open the windows. If you have to go by taxi, ask the taxi driver to open all the windows and say it's because of you. I want you to do it because I might be sick, you know, and I might transmit the virus to you. So
that was some concrete guidelines to round up. As we bump up on time here. We're coming up on 11 here in US and I guess 8 in Sweden. Some last words, questions, Saga, from your side, Lars, from your side?
I would just like to say thank you for all your questions. We're sorry that we couldn't answer all of them, but I hope you found the discussion interesting and that you got some new more information about the topic. There will be a short survey to fill in when you exit the webinar, so please feel free to write your thoughts and feedback there. We will really appreciate it. So
thank you everyone for listening in.
One last question. Were you surprised that Trump didn't get hydrochloroquine when he was hospitalized?
No, when you're hospitalized, that's, I mean, if there is any effect of hydrochloroquine, then you should have taken it before, and it did, of course, as far as I understand. Maybe that was beneficial. I don't know. It's but when you're sick, it doesn't help to start treating with it, that's for sure. I was a bit surprised of that I didn't use interferon, because interferon is very effective. But they gave him famotidine, which is a new drug. And well, it's not a new drug as such. I mean, you use it for peptic ulcers and, you know, for it's been used a very long time, so but it's been shown now to have an effect on the virus, and it was giving this antibody cocktail. So I think he's the president. Of course, he will get more, and then the king would also in Sweden would get more treatments and experimental, if you like. I mean, I wouldn't even call it experimental. I mean, it's I wish if I got sick, I would do it. On the other hand, I boost my what we call innate immunity by vaccinating myself with live virus vaccines, like the MMR vaccine, the mumps, measles, rubella vaccine, and the zoster. There's a zoster vaccine, and you could use rotavirus. And maybe you heard in the States also that Bob Gallo, whom in my opinion should have received the Nobel Prize for HIV, he's been advocating oral polio vaccine, which is a live vaccine, for boosting the innate immunity. And it's quite interesting, you know, that back already in the 50s, they found in Moscow a physician that those that she vaccinated with the oral polio vaccine, the live vaccine, in the coming influenza period, they didn't get influenza. But those that hadn't gotten it, got influenza. So, and it's because of, amongst other things, interferon. We start producing lots and lots of interferon. And coronavirus are extremely sensitive to interferon. And hence they have, adopted this stealth technology. Lots of their genome is actually there to for the virus to creep under the radar, so that the virus infection doesn't induce interferon production. Whereas with the other normal viruses, the first thing they when you're infected, you start producing interferon, and normally you get well from a virus infection long before you have the ability to produce antibodies and T-cell immunity. So that was a little bit surprising that they didn't give him interferon.
Thank you.
Thank you, Lars, for that last question. I think that opened up for a whole new webinar on treatments and maybe the difference in treatments with presidents and kings and the rest of us. But we have to take that another time. So thanks for everyone listening in. Thanks, Lars and Saga, and very much appreciate, Anders, that you came along with us here today, and hope you out there who are listening maybe to this later will enjoy it too. Have an excellent evening if you're in Europe, and excellent day if you're in US. Bye, and talk to you soon.
Thank you.
Thank you very much.
Bye.